Hello, everyone. My thanks to the organizers for the invite to present today. As you'll see, my topic brief is osteoporosis and HRT. I will set some background, and in the second half of the presentation, I'm hoping to look at practical HRT prescribing issues. By way of introduction, my name is Tanna. I'm a consultant pharmacist, and I work at Northwick Park Hospital, where we run weekly menopause and osteoporosis medication management clinics. And essentially, it's basically where we work with patients, use the shared decision-making protocol and help patients make a decision about what treatment they want to go for. When we think about osteoporosis, let's go back to 1990 and this graph where actually we note that both men and women achieve peak bone mineral density by the age of about 30, go through a period of consolidation between 30 and 40 years of age, and then gradually by the age of 40, both sexes are losing about 1% of bone mineral density. But in the case of women, they go through menopause, which is a natural end of the reproductive phase. Ovarian function declines, estradiol levels drop, and women will have sharp accelerated bone loss. So that can be approximately 5 to 6% before they stabilize. I think the most important point from this graph is the fact that women will reach the fracture threshold much earlier than men and are at higher risk. So when we think about the early studies, we've got some good studies which have shown that HRT, so that's estrogen particularly, helps with maintaining bone mineral density. So there is a bone mineral density benefit. HRT acts as an anti-resorptive agent, and there's some recent work which says that it could actually help with improved bone formation quality and mineralization regulation. However, the question that we've always had in this field is that just by maintaining bone mineral density or making sure that you prevent loss, does that actually equate to fragility fracture risk reduction? And the Women's Health Initiative studies were very, very important. The first large randomized controlled trials, which included various study arms. They studied both estrogen only and then the combined HRT regimens. And this was the study that actually showed a significant improvement or a significant risk reduction with regards to fragility fractures. So that's quite an important study to think about. Thinking about osteoporosis, the definition that we work to now is that it's a skeletal disorder characterized by compromised bone strength, and it predisposes a person to an increased risk of fracture. So we've now gone into the scenario where currently we would actually do a FREX assessment or a Q fracture assessment. These are computerized prediction algorithms. They include other clinical risk factors for the patient in front of you and give you an idea of their risk for multiple osteoporotic fracture or hip fracture. And this is where you calculate the 10-year probability of fracture using the FRAX tool. Moving on, I think this slide is very, very important. I would like to acknowledge that the fact that I've adapted the table from the publication in Menopause International in 2011. But essentially what it shows us are all the treatment regimens that were available at that time for fracture risk reduction, what sort of benefit we had, what sort of risk reduction we had in the context of vertebral fracture risk reduction and hip fracture risk reduction. And what's interesting to see is that the ones that I've highlighted in red, so you've got raloxifene, which is a SERM, or the HRT here at the bottom in red, with HRT combined, for both vertebral fracture prevention and hip fracture, you've actually got a benefit of something like 34%. And SERMs and the HRT, the study population studied were not selected with the diagnosis of osteoporosis. The study cohort included patients, women, with the diagnosis of osteopenia. So this is quite important when you're actually thinking about where to place a treatment, what sort of patient profile the treatment would be suitable for. When we think about HRT risks and benefits, we had the MHRA table published in 2019, which included the data set from WHI. And at the moment, we're now using the NICE NG23 menopause guidelines. These were updated in November, so very recent. And the benefits for HRT would be vasomotor symptom control, sleep, low moods and anxiety, sexual health scenarios, but essentially marked in red what we are thinking about in the context of the presentation today is the bone protection, the osteoporosis risk reduction, and fracture prevention. The risks that women need to think about or need to be advised about when they're considering HRT is with relative to breast cancer risk, strokes and thrombosis, and any other based on the patient medical presentation. What NICE is saying is that when you think about fragility fracture for women around menopausal age in the UK, the baseline population risk is low and it varies from one woman to another. And what we need to explain to women is that their risk of fragility fracture is decreased whilst taking HRT, and that this benefit is maintained during treatment but decreases once the treatment stops and may continue for longer in women who take HRT for longer. Focusing on osteoporosis here, and these are the statements, but what we need to remember as health professionals is that when you give HRT to a patient, you're actually adding in additional benefits for menopause symptom control. And currently the evidence base runs from natural menopause, which is around 50-51, to age 60-65. We did some in-house work at London Northwest Hospitals. This was collaborative work between the Metabolic Bone Disease Clinic and the Menopause Clinic, and we designed a theoretical framework. So this is going back in 2005, which is where we started. In our current practice, we offer HRT in early menopause, so premature ovarian insufficiency, and then at the time of natural menopause, where before in 2005 we knew we had an evidence base for use of HRT for up to 5 years, but where now the evidence base is stronger for between 50 to 60-65. So let's look at prescribing HRT. Just to make sure that we're on the same page, I'm just going to go through some terms that I'll be using. So when I talk about menopause in the Greek language, it means the last period, but women actually go through a phase where ovarian function declines, and that phase is described as climacteric. When I talk about somebody going through the perimenopause, what you're saying is that actually the woman has still got some endogenous hormone cycling, may still be presenting with bleeds, but it's going to be erratic. When we talk about postmenopause, we are actually saying that we're defining this retrospectively, where a patient walks into a clinic and we sort of say, when was your last normal menstrual period? And if it was 1 year or more before, that means there is no endogenous hormone cycling going on. They've actually stopped having menstrual cycles and they're bleed free. So if they've been bleed free for 1 year or more, they're classified as postmenopausal. And these definitions are quite important when you think about hormone replacement therapy. So the first one I've got on my slide, the sequential combined therapy. These are regimens where you give estrogen throughout the month, progesterone for half the month. It mimics the menstrual cycle. And when the patient settles, she should expect to get roughly regular monthly cycles. Sequential combined therapy can be used in either phase, perimenopause or postmenopause. Postmenopause, particularly if our young patients who actually want to have monthly bleeds, who do not want to accept a no bleed profile. Moving on to continuous combined treatments. This is continuous combined estrogen and progesterone right through the month. There's a settling time of about 6 months, only licensed for postmenopausal women. So you're starting with women who are postmenopausal, not bleeding, with a sort of atrophic endometrium, and then you stabilize them on a continuous combined treatment. It does take up to 6 months to settle, but then they should be bleed free after 6 months. If they're not, we need to investigate. Now, when would we use unopposed estrogen? The textbook answer is when a patient has had surgical menopause. So when you talk about surgical menopause, they've had a total abdominal hysterectomy, they've taken out the uterus. They might have left the ovaries intact or might have taken out the ovaries, but the uterus is out. And if the uterus is out, then these patients can be just prescribed estrogen on its own. They don't need the progesterone part for endometrial protection. And then we've got additional options, the vaginal estrogen replacement therapy. These are very low dose regimens formulated for local symptom relief, usually prescribed for urogenital syndrome symptomology. Some facts: the average age of menopause in the UK at the moment, we accept that as 50-51, but we do know that the climacteric phase can last anything between 45 to 55. 1% of women will go through a premature ovarian insufficiency. And I just want to sort of share with you the definitions as per World Health Organization. Menopause before age 40 is classified as young menopause. Between 40 to 45, it's early menopause. We know that we are all living longer, and women could expect to live something like 30 to 40% of their life after the menopause. They will be symptomatic. They will get perimenopausal symptoms. 25% of women complain of severe menopausal symptoms. And just flagging up that the SWAN study arm, SWAN is the study of women across the nation in the US. It's been reporting its data, and it's telling us now that women could go through a natural menopause and struggle and be symptomatic. So they have their hot flushes, night sweats for an average time of 7 years, but some outliers could struggle for up to 12 years. So we've got to discuss the HRT risks and benefits. And on this slide, I just want to flag up that when you look at the NICE NG23 guidelines, which were recently updated, the data for added risk is calculated over 7.5 years for HRT use for breast cancer and cardiovascular disease. But for osteoporosis, we've only got randomized controlled trial ranging between 3 to 5 years. So that's the data that's been incorporated when they look at risks and benefits. And just to actually give you a link for the Self-Care Forum patient information leaflet on menopause, which we are using for our patients when they come in for a consultation. So just to refresh our mind, just let's look at this graph here. This is actually the menstrual cycle. It's demonstrating the systemic cyclical circulation of estradiol and natural progesterone. So we get estrogen throughout the month, a dip halfway, which means that the young lady is ovulating. If she has intercourse, she can be pregnant. If she doesn't have intercourse, in the second half of the month, we get this progesterone coming in. The function of the progesterone is to slough off this endometrial lining that's been stimulated. If that endometrial lining that has been stimulated is left in situ, it can convert to hyperplasia and then malignancy. So the progesterone plays a very important part. If the young lady doesn't get pregnant, then the function of the progesterone in the second half of the month is to actually help shed that stimulated endometrial lining. With HRT, we are using these hormones, estrogen and progesterone. It's physiological replacement. In the UK, we are now trying to use more of the natural options. So the 17-beta estradiol or the estradiol valerate. And then when we add in progesterone, we've now got natural progesterone licensed and available in the UK. These products have been around for 5 years, but before we didn't have the natural progesterone available. So we used to use the C19 testosterone analogs or the C21 progesterone analogs to provide the endometrial protection. And just finally, just to flag up that if you've actually got premature ovarian insufficiency, you could do the FSH levels 4 to 6 weeks apart. So this is the follicle stimulating hormone. And if those levels are over 30, then the patient can be given a diagnosis of premature ovarian failure. On this slide, I'm now actually using a resource that's can be quite useful. These are the MIMS table. They're available in primary care to GP practices. But essentially, the first part of the table logs all the HRT products that are sequential combined therapies, the brands, the estrogen and the dose, the progesterone and the dose, the type of formulation, what the patient can expect once they've settled. So here you've got the monthly bleed. There's one product that gives you quarterly bleeds that we can use for specific patients. But essentially, for the monthly bleed products, you're providing estradiol throughout the month, and then with progesterone or progestogen for half the month. And after settling, the patient should actually see monthly cycles. Talking about the progesterone, the C19 analogs, we've got norethisterone and levonorgestrel. They are testosterone analogs, so the patient may get androgenic side effects, but they are the better choice for bleed control. When would I choose progesterone analogs, particularly dydrogesterone? These would be quite important for cardiovascular profiles, and dydrogesterone does not have any affinity for androgen receptors. MPA, so that's medroxyprogesterone acetate, sits somewhere in the middle. Essentially, just remember, when you prescribe sequential combined therapy, we are giving estradiol throughout the month with progesterone for half the month, and the patient should be advised that to expect initial transient side effects, and these take about 3 to 4 months to settle. Continuous combined therapy. This is the next part of the table in MIMS. These are all the products that are available. These are licensed only for postmenopausal women with the last normal menstrual period of 1 year or more, can be prescribed continuous combined therapy, and it can take up to 4 to 6 months to settle. A couple of products that are different slightly in the pharmacological way that they work. So we've got Livial or Tibolone. This breaks up into 3 isomers, gives you estrogen benefit, progesterone benefit, and androgen receptor affinity benefit, licensed for postmenopausal women, and is an alternative to no bleed HRT option. Ospemifene is interesting. It's a new product that's just recently been launched, licensed for moderate to severe symptomatic vulvar and vaginal atrophy, licensed for use in postmenopausal women. But essentially, in our practice, we would always try and stabilize our patients with vaginal estrogen replacement therapy. But there may be some patients who would benefit for something that can be given orally in this sort of case scenario. Unopposed estrogen, again, stressing, these would be used in patients with surgical menopause where you don't need to think about endometrial protection. But if they have an intact uterus and you want to use estradiol from one of these sort of one of these options, then if the patient has an intact uterus, you must add in progestogen. Lots of different formulations available, and just flagging up that the patches, the spray, the gels are your first line options for any thrombosis risk in the patient presentation. Adjunctive progestogens, we've got these choices. I'm just going to flag up Mirena because it's very interesting. It's an intrauterine system. It's licensed for menorrhagia, so heavy bleeders. It's got inbuilt contraception and can be used as the progesterone component of HRT. So for example, perimenopause patients with heavy bleedings or erratic bleeding, it would make sense to give them Mirena, add in the estrogen, maybe the gel or the patch, and they've got HRT and with inbuilt contraception. So these are vaginal products. Again, lots of different types of formulations, gels, rings, creams, essentially licensed for local symptom relief. So you've got vaginal dryness, you've got a loss of libido, but where it's actually the vaginal dryness that's causing the problem, or you might have recurrent UTIs. These options are suitable for that sort of patient case scenario. This is an interesting slide. It picks up on the fact that we need to think about the holistic management plan for the patient-prescribed HRT, where lifestyle interventions can be quite important. So for example, if you actually maintain weight, you don't take alcohol, your BMI is low, then these are some of the things that can mitigate risks for HRT, breast cancer risk for HRT. It could actually also be important for the patient to take on board the fact that HRT comes with risks which can be mitigated with lifestyle interventions. And just flagging up that if you use long-term HRT, and in that time we used to provide HRT for 5 years, describe the risk benefit in the context of 5 years usage, then that's the same risk as giving birth to your first child 30 years plus. So thank you for your kind attention. I've given you a lot of information. I'm looking forward to the question and answer session. My last slide, I've just added in some references that you might find interesting, that you might want to look at if you want a little bit more information on some of the information I provided today. Thank you very much.